Thank you, Ben. Thank you, Dr. Siddiqui, Dr. Mopsis, and thanks all of you for inviting me to speak. Welcome to all of you. So Ohio, Georgia, and California, all places that are typically colder than Detroit, except for this is just an anomaly for us this week. But welcome to all of you. We hope it's a worthwhile experience. We're excited to share some of our knowledge and collaboration. And I guess the one thing I want to emphasize at the beginning is that this is a true partnership, at least here at Henry Ford, between neurosurgery and radiation oncology. We really consider ourselves members of the same team, and I think that in the end that benefits our patients the most. So in the next hour, Dr. Siddiqui and I are sort of tag teaming the concept of brain metastases, and I think we thought what we'd do is I would sort of give an overview of where the national guidelines, at least on the neuro side, which are very similar, by the way, to the Astro guidelines, are in terms of treatment for brain mets, how we think about it, things we discuss in our tumor board, and then turn it over to Salim for more of the practical planning aspects and so forth. One of the things that I wanted to mention at the outset here at Henry Ford is that in the last couple of years, in addition to our Josephine Ford Cancer Institute, we've started a center called the Center for Cancer Surgery, and it's a way of bringing together all of the various aspects of surgical oncology across multiple disciplines. So not only brain, but lung and breast and OBGYN and head and neck and prostate, and the list goes on and on. And I guess I'm very proud to say that radiation oncology is an integral part of the Center for Cancer Surgery, because radiosurgery is part of the continuum of what we can offer our treatment in terms of surgical, targeted, and focused therapies. This is what we're here to talk about today. I have a couple disclosures, but this slide is something that plagues many of our patients. It's at first seemingly simple. You think, okay, well, you have a single brain met there causing some edema and swelling. What do you do about it? And if you are just beginning to look at the mountain of literature on this, you may think, well, maybe whole brain radiation therapy, maybe surgery, maybe radiosurgery, maybe surgery followed by whole brain radiation therapy, maybe surgery followed by radiosurgery, maybe radiosurgery by itself. And you can begin to see that the permutations are endless. And so we needed to sort through these various permutations to figure out what in fact the evidence shows and what it is that we're dealing with. The one thing we do know for certain is that this is a very serious problem in our society. 1.2 million cancer patients diagnosed in this country every year, and depending on the series that you choose to review, up to 40% of these patients, or nearly 500,000 people, will develop brain mets every year. Most of these, by far, come from lung and breast, but many primary cancers can go to the brain. We know that survival is related to how well the primary disease, or the so-called extracranial treatment, progresses, and survival is also related to how aggressively we treat the brain disease, because we now know that a quarter of our patients succumb to the CNS progression of their disease. But that means that 75% of our patients do not, and this is an opportunity to really make a difference for patients who have brain mets. We also know that aggressively controlling the intracranial portion of the disease improves quality of life, and it reduces the rate of death from neurologic causes. And when you do this, in fact, prolonged survivals are possible. Before the advent of radiosurgery, I think the world was in balance. People thought they had it all figured out. If you had a surgically accessible lesion, boom, you just did surgery and you followed it with whole brain radiation therapy. If it wasn't surgically accessible, maybe you did radiosurgery, maybe not. Radiosurgery now has revolutionized the treatment of brain mets, and in fact, the indications for radiosurgery are more and more every day. And so On the neurosurgery side, we wanted to take this concept of how to treat brain mets with all these various permutations and put together all of the evidence available. And I was honored to lead a team a few years ago that did this, and we're actually in the process now of updating the guidelines with new clinical trials. But the reason that I think personally some sort of treatment paradigm analysis is important is because here we have the most common brain cancer. Ironically, most number of patients with cancer in the brain are brain mets, yet there's no national consensus regarding the best treatment paradigm. You have the most high quality data for any other type of cancer imaginable that can be used as a guide for therapies, but there's extreme variability in patient care. There are many reasons for that. There's lots of interpretations of the existing data. A lot of it depends on where you trained, economic factors, the types of equipment that your hospital has, the degree, and this is an important one, of multidisciplinary cooperation between surgery and radiation oncology and medical oncology. But at the end of the day, we still have very little knowledge on critical outcome measures, especially quality of life and neurocognition. So we put together a set of guidelines that looked at various aspects of the treatment for brain mets, including what is or should be the role of whole brain surgical resection, obviously stereotactic radiosurgery, chemotherapy, what to do about recurrent mets, when do you use anticonvulsants, steroids, and then new and emerging, what we call novel treatment therapies. And for each chapter, to me, this is the most important aspect of the guidelines, not so much what they say or what the state of the evidence is today or a couple of years ago when we did this, but essentially outlining where the gaps in our knowledge are so that we can highlight, in fact, where more research is needed to shunt patients into clinical trials and to encourage more research to get a handle on some of these answers. And so what we did is followed our neurosurgery parameters for developing guidelines, which is really a two-step process. First, we systematically ranked all the evidence in terms of class 1, class 2, class 3. Class 1 meaning the gold standard, randomized controlled clinical trials. And then we linked those pieces of evidence directly to levels of recommendation. And so you could have 1 million class 2 studies. That would never generate a level 1 recommendation. You can downgrade, but you can't upgrade. And so it maintained, I think, what we call the fidelity of this methodology, in that when we say that there's a level 1 recommendation, then we know that recommendation is directly backed up and linked to very high quality evidence, specifically class 1 evidence. And the cartoon at the top is really meant to show that whenever you put 2 surgeons in a room, there's probably 5 or 6 different interpretations of what should be a basic number. And so guidelines, in fact, are important to help guide us. We started with about 27,000 articles for all of these 8 chapters, and after we did a validation analysis, we sifted that down to about 600, which then turned into 310, which actually addressed a head-to-head treatment scenario. In other words, stereotactic radiosurgery versus whole brain, and the list goes on. Here's just a very busy slide explaining one snapshot of some of our evidence tables looking at surgery versus surgery plus whole brain radiation therapy, and then at the bottom, surgery plus whole brain versus radiosurgery alone. And when we did this, we were able to compile and put together a set of guidelines that was published in the Journal of Neuro-Oncology. It was actually endorsed by all of our parent organizations in neurosurgery, including the CNS and AANS, but also by ASTRO and the Society for Neuro-Oncology and the Joint Section on Tumors. And so we're proud of the outcome, but I think that, as with any guideline series, it's never meant to give, quote unquote, all the answers, but really a roadmap in terms of what you should be thinking about. And before we get into the actual guideline recommendations, I think a few things have come forth in terms of what, in fact, we do know about how to treat brain mets. You can treat it focally or systemically or both. Unlike primary brain tumors like gliomas, mets are fairly well circumscribed. And sometimes when they get big and they cause mass effect and edema and midline shift, like you see here, sometimes surgery is important and it's necessary to perform a resection. And there's 4 basic choices. You can do whole brain radiation therapy, surgery, radiosurgery, and then there's this question of chemotherapy or some combination of the above, and that's what the guidelines really aim to sort of tease out. We know, just as a bit of historical knowledge, that in fact whole brain radiation therapy was the treatment of choice for brain mets. It's still used today, especially in patients who have multiple lesions or poor performance scores, and it's an important adjunct to surgical resection. But we all know now that radiosurgery has gained tremendously in prevalence and capability around the country, and radiosurgery is now a standard treatment option, especially for those lesions that have very high surgical risk. The question is, what about for those lesions that can be treated with all of the modalities? What's the best for our patients? Well, we went through each of these questions and came up with a series of guidelines. The first involved what to do about whole brain radiation therapy, and we asked the question, should whole brain be used as the sole therapy in patients with a newly diagnosed single brain met compared with whole brain plus something else, in this case surgery? And a level 1 recommendation came back and really turned on its head this historical treatment paradigm that had been followed for decades, and that is no. Whole brain radiation therapy is not appropriate for these lesions. In fact, patients do much better. They're more functionally independent, and they have better survival when whole brain radiation therapy, if anything, is used simply as an adjunct to surgery, or as we'll see in a minute, stereotactic radiosurgery. We also looked at optimal dosing and fractionation schedules, and it turned out there weren't any significant differences, and there wasn't actually sufficient data to suggest that histopathology, believe it or not, made a difference in the outcomes for whole brain radiation therapy in many of these cases. We then flipped it on its head and asked about surgical resection and set up several kind of head-to-head scenarios. Surgery followed by whole brain versus surgery alone. Well, you'll see in every one of these instances that when you combine a focal and a systemic approach, you actually get a better option than just doing surgery alone. And I think that this is intuitive. Obviously, if these metastatic cells traveled to the brain from somewhere, and so just by taking it out surgically, there clearly is likely to be microscopic seeds that are left behind. And so the evidence to a level 1 degree suggested that surgical resection followed by some sort of radiation therapy was far superior than just doing surgery alone. A lot of this was from the early Patchell data, but has been borne out time and again in more recent studies. And this was true for both local and distant tumor control. Well, this is where the tide started to turn in the favor of radiosurgery, because we then looked at surgery followed by whole brain versus radiosurgery followed by whole brain. And you have here level 2 and level 3 recommendations, mainly because there just simply wasn't enough class 1 evidence available that for the first time suggested that radiosurgery was just as good as surgery for many of these lesions. Here are the caveats. The data was not as robust when we were looking at larger lesions, and we define those as greater than 3 centimeters, or for those causing significant mass effect. And so for lesions that had a lot of mass effect and that were quite sizable with a significant amount of edema, we tended to point to the evidence to say that surgical resection was more appropriate. But for any other lesion, radiosurgery was equally as good. There was also conflicting evidence, because a lot of these were not powered properly statistically to allow it to rise to a level of statistical significance, that radiosurgery alone, without any sort of adjuvant whole brain radiation therapy, could actually provide equivalent functional and survival outcomes when compared with the gold standard, which is surgery followed by whole brain radiation therapy. And again, the caveat was, as long as you're making very sure that you're following these patients very closely over time to initiate salvage therapy if a recurrence should occur. Well, here was the final sort of underpinning of why radiosurgery has gained so much prominence in the literature and in our practice over the last several years. Because when we looked at every option that had radiosurgery, by far it was the winner compared to the options involving whole brain radiation therapy alone or even surgery by itself. But adding stereotactic radiosurgery to treatment for brain mets produced longer survival for single mets. It produced better functional status for multiple mets, up to 4. It produced longer survival for 2 to 3 mets compared to whole brain radiation therapy, and for single or multiple mets, even if the performance score was less than 70. So these were all very significant findings that led to the promulgation of recommending radiosurgery often by itself. And this second batch here, where we're comparing radiosurgery plus whole brain versus radiosurgery alone, to me this is the most important thing that came out of all of the guidelines recommendations, because this raised the question for the first time: is whole brain radiation therapy even necessary? Do you actually need to go through the process of whole brain radiation therapy and potentially spare patients, in theory anyway, decreased mental status changes and cognitive changes and so forth? And the answer, in fact, was radiosurgery alone does a pretty good job. It had equivalent survival in many of these studies that were analyzed. And again, the caveat is that when you're not giving a systemic treatment to the brain, meaning a whole brain radiation therapy approach, you have to do regular careful surveillance so that you can detect early recurrences. But given that, SRS alone was equivalent and effective, and in fact has only continued to gain in prominence since then. So if you think about a few cases, surgery versus radiosurgery, you have to come to a sense of clinical equipoise. And I put a few examples here to really make sure that everyone understands at least what we go through in our tumor board discussions, because I think it's not a one-size-fits-all approach. And I guess that's the danger of the guidelines, that you don't want to set up a cookie cutter, sort of cookbook medicine kind of recipe, but rather to give touch points and pathways where you can refer back to when you have an individual patient concern. So here in this situation, there's a large cystic lesion. It's clearly more than 3 centimeters. Only a small portion of it represents solid tumor. I think the literature here would suggest that radiosurgery is not appropriate for this lesion, that surgical resection to reduce the mass effect, to drain the cyst, and at the same time remove the enhancing portion of the lesion is a far better option for the patient. But this is a different story. This is a single metastatic lesion. It's obviously very close to the motor strip, but yet with mapping and with our intraoperative MRI and functional imaging and so forth, it is very resectable, but it is also very amenable to radiosurgery. So in this situation, I think this does fulfill the question of clinical equipoise, meaning you are equally torn between 2 options and the evidence doesn't show overwhelmingly in favor of one or the other. This is something that we see in tumor board every week, and really depending on the situation, I've seen, I think, and Ben and Salim, I think, and Farzan will agree that over the last year or two, we've been really moving toward radiosurgery for lesions exactly like this, because of the concept that we could spare not only the active surgery itself, but given proximity to critical structures, potential damage to the motor strip and so forth. This one is a little bit more difficult because obviously lesions in the back of the brain, when you're starting to deal with the posterior fossa in particular, have, we worry a lot about mass effect, but we've had experience where, if you do radiosurgery and watch these patients and put them on steroids and so forth, and if they're clinically stable, then you can actually do radiosurgery with, I think, pretty excellent results. But this is maybe a little bit more on the surgery side of the spectrum. When you put this all together, I think that the guidelines have told us anyway that here's sort of the paradigm that we work with when we see these patients. On the surgery side, followed by whole brain radiation therapy, we typically perform surgery in patients that are large for obvious reasons, and in our series here we've defined it as greater than 4 centimeters. Those that have significant mass effect, either a 1 centimeter midline shift or anything in the posterior fossa that's starting to abut against the fourth ventricle. If it's a very superficial location and eminently surgically accessible and it's too hard for us surgeons to resist going and taking it out, then potentially. But I think that even those are being called into question, and again, that gets into that equipoise discussion. But this is an important one. When the diagnosis is uncertain, this happens more than you know, even in the classic patchal data. Believe it or not, and this is a little known fact, 10% of the patients who were enrolled in the original patchal study in the 90s did not have brain mets. And so this is a pretty critical finding when you think about, it is very important to know exactly what we're treating. And especially in the age we live in now, thankfully, with precision medicine and targeted therapy, we are proud to have one of the largest tumor banks in the world here to offer the molecular genetic testing for personalized medicine. We absolutely need the tissue to know what it is that we're talking about. And so when the diagnosis is known, when they have an obvious primary, or if it's a recurrence, that's a very different story. But when the diagnosis is uncertain, even if it's a smaller lesion that would be easily treated by radiosurgery, sometimes surgery is important for those very reasons. On the radiosurgery side, you can imagine that deep lesions that are surgically difficult or fraught with significant risk, if they're quite small, if the patient is sick and has several comorbid conditions and they're deemed a poor anesthesia risk for surgery, again, that lesion near the motor strip that we showed earlier, lesions that are near critical eloquent brain structures, a lot of times we'll do better with radiosurgery. And if we know that the histology is particularly radioresistant and they wouldn't necessarily respond as well to whole brain radiation therapy, then we would err on the side of radiosurgery as well. So this does not always apply to every single lesion in a hard and fast way, but many times it really helps clarify many of the questions that were faced. So getting back to all of these options, radiosurgery and open surgery and perhaps novel therapies and viral vectors and immunotherapy that are just coming on the scene for brain mets. The guidelines help us in terms of understanding, I think, the importance and role of radiosurgery and what it can do for our patients. And one thing I wanted to just sort of point out that when we started this adventure with the guidelines, and I don't really think we're having a fire drill here, but hopefully that will stop. There were actually, as I said before, about 27,000 hits on a PubMed lid search for brain mets from 1990 to about 2009 when we started putting the guidelines together. After we put out the guidelines in the last 3 or 4 years, and this was only looking at a snapshot to 2012, you can imagine now in 2015, the number of articles in the last 5 years has completely eclipsed what it was in the last 20. And that's because there's a huge emphasis on new and innovative therapies. Before, no one knew what to do with brain mets. When I was a neurosurgical resident a decade and a half ago, I remember very distinctly getting consulted on patients from the floor with brain mets, and as a neurosurgeon, we would just sign off and say, plan per medical oncology or plan per radiation oncology. Now it's the opposite, and I think it's really broadened the need for cooperation between surgery and radiation oncology and medical oncology, but it's also, I think, helping us understand the pathophysiology of this disease and where it's going. And because of that, I think in the service of our patients, we're really forced to ask the tough questions. Has what we've been doing for the last 20 years, is it actually making a difference? Is it the right thing to do? And there's been a lot of emphasis lately on cognitive changes and neurocognition and the risk to that from whole brain radiation therapy. And a series of patients papers beginning in 2009 and as recently as a few months ago, this paper by Chang and his colleagues from The Lancet really started to ask that question. Again, that was borne out, I think, by some of the work we did on the guidelines, and that is, do you really need whole brain radiation therapy added to SRS or any treatment for that matter when, controlling the growth of brain tumors, is it really outweighed by what's at risk from neurocognitive decline? And when they looked at this, they found that patients who had stereotactic radiosurgery alone had the least cognitive decline, both in delayed recall and in delayed recognition. And they did a whole series of tests, the Hopkins Verbal Learning, the Lafayette Groove Pegboard test, and many others that are listed here. And this is what's interesting. The green curve shows where the patients started out as. The blue curve is radiosurgery alone. And the event probability along the x-axis, the further out you go to the right on the x-axis, suggests that you have a much higher probability of cognitive decline. And you can see that when you add whole brain radiation therapy to stereotactic radiosurgery, it jumps from about 24% to 52% in terms of the probability of neurocognitive deficit. So then we said, well, all right, maybe these patients will have a neurocognitive deficit, but if they're living longer, then perhaps it's worth it. And the data, again, did not suggest that. In the Chang paper, it was pretty stunning that the median survival in patients who were only given radiosurgery for their single brain met, and this study was up to 3 mets actually, was nearly 3 times longer than those who had gotten radiosurgery and whole brain radiation therapy. And look at the 1-year survival rate, 73% to 27%. Obviously, we gave up something on distant control, but it really doesn't matter if the patients are living all that much longer. And so this was something that I think really changed our thinking in favor of radiosurgery. Other studies, the Coker study from 2011, also, although not to as significant a degree as the Chang study, suggested that patients who had no whole brain radiation therapy added to their SRS regimen compared to those that did have radiation therapy, the survival and functional independence were not appreciably improved or impacted in any way by adding whole brain radiation therapy. Now, whole brain does reduce the rate of intracranial relapse and the rate of neurologic death, but the most important parameters to patients, meaning their degree of and duration of functional independence and how long they actually live, were not affected. And so I think now there's been at least some consensus in the literature and in our practice that for patients in particular who strongly associate memory and learning preservation with quality of life, and those same patients then need to accept the possibility that there may be a higher rate of distant mets or distant spread, and there may need to be salvage therapy later on. Given that, there's class 1 evidence now that suggests that radiosurgery alone is in fact a reasonable and effective strategy to manage brain mets. And this is something that certainly is very new over the last 5 to 10 years compared to the entire history of brain mets in the decades before. We're already doing a practice here that's a little bit ahead of the literature because a recent clinical trial came out, and there's many studies now showing that even when you do surgery, it's not always appropriate to do whole brain radiation therapy like the guidelines initially said based on the evidence we had at the time. But in fact, you can do radiosurgery to the resection bed once surgery is performed. And looking at 14 major studies involving 614 patients through a few months ago in October of 2014 suggests that the overall median survival is 14 months, which is higher than the numbers from whole brain radiation therapy, and there's actually good local control, 83% versus 50% at 1 year by doing radiosurgery to the resection bed. So again, this I think is going to be something that continues and gains in prominence. In other words, even for those larger lesions or for those that you don't have histology for, that you need to do surgery, radiosurgery to the resection bed is important. I put this slide in here to say that there are other options as well. We're here to learn about our radiosurgery capabilities, but for those lesions who ultimately fail radiosurgery, and for patients whom we have no other recourse, we are now using laser heat ablation thermotherapy. We have the Visualase system here, where you're essentially able to put a probe into this lesion, and it treats it whether or not it's a metastasis or radiation necrosis, and you can heat it up in an intraoperative MRI. The images come up on screen, and in real time you can look at a zone that has a border of less than a millimeter of drop-off between where the treatment zone is in the kill field, if you will, and the surrounding normal brain. And so this is something that, if SRS fails, we do have other technologies coming on scene that I think are very complementary to what we're doing in terms of offering radiosurgery to our patients. So a few things about Henry Ford and our tumor board process. This is a typical Wednesday afternoon at 3 o'clock. We see about 700 new brain tumor patients per year, 7,000 patient visits, and about 2,000 tumor board evaluations. Many times we have 50 or more patients on the list. And this group is comprised of our neuro-oncologists, our medical oncologists, our pathologists, our radiologists, our neurosurgeons, of course, our radiation oncologists, our clinical trials nurses, and it really is a great way of getting 20-second opinions for one patient all at once to come up with a coordinated plan. And we have about 3,500 tissue specimens in our tumor bank that is really helping us develop some of these new paradigms for personalized medicine. We're thrilled to have the Edge here, and again, I just want to emphasize that from the day this arrived to the planning that's done currently, it truly is a collaborative effort between all of our departments, and thanks to Ben and Salim and our entire radiation oncology group, that has been something that has been part of our culture here, and at the end of the day, it makes treating these patients I think quite effective. And the last slide I'll leave you with is that it's been interesting to me in studying this concept of brain mets over a period of time that historically the incidence was thought to be about 100,000 patients a year. We know our patients get more imaging than ever before, more early imaging than ever before, more surveillance imaging than ever before, and we know now that this number has nearly quadrupled. 400,000 patients, which dramatically changes the burden of treatment for those of us who see this disease. As we mentioned, whole brain radiation therapy for decades, starting in the 1980s, was really the only option offered. But over the last decade, that has changed to include surgery and radiosurgery. The interesting thing to me is that, by and large, most patients with brain mets died from their brain disease up to about 6 years ago. And since that time, the number has shifted dramatically, and now patients, because their intracranial disease is being so much more aggressively treated, their cognition is better, their quality of life is better, and when they actually succumb to their disease, it's because of an active primary disease, not necessarily the brain disease. We already talked about the role of the surgeon being expanded to one of an active participant in these patients, and I think that has enhanced our level of understanding and collaboration, and truly this has been made possible by the concept of a multidisciplinary tumor board, which is not something that should be done in just academic centers, but truly every place, every hospital, every group who treats these patients needs to be aware of the interplay between surgery and radiation and medical oncology, and I think in the end that's something that will help everyone. So thanks for your attention. Happy to answer any questions, and I think Salim is going to come in and do the practical applications for this. So thank you.